That's right, it's KP's Video News, and this article that I'm going to come to you right now is extremely important and extremely real. This is not fictitious, and I would definitely put the link, add the link to my page, and so you can go see it and you can read the article for yourself. However, this story is really scary, and it has to do with a bioethicist on why reopening states will kill more black people. And this is something that I've been noticing anyway, because it's like I've been seeing like a disproportionate number of black people, even those that work in the medical fields, that have been denied testing and have been denied access to the hospitals. And so now this is like a science lab on the streets. You know, black people are being used once again as guinea pigs for this virus. So let me read the story here, and then you can determine what you want to think about it. There's a long history of medicine and government choosing who shall live in the name of science and economics. As of April 28th, the United States surpassed 1 million confirmed coronavirus cases, but this hasn't stopped more than half of U.S. states from partially reopening or making plans to reopen soon. Prematurely restarting businesses means new virus cases will arise, health officials say, especially in the face of insufficient testing. This puts the country's most vulnerable populations, black, Latino, poor, elderly, and disabled, at a greater risk of infection and death. For the black community, the decision to reopen, despite the alarming rate and the alarming data that shows that they are disproportionately suffering from the disease, black people make up 30% of the coronavirus cases, according to the CDC, even though they represent only 13% of the U.S. population, fuels the community's distrust of government and health leadership. It harks back to the cruel historical practices that use black bodies as scientific silly putty. The event most cited to explain this historical distrust is the U.S. Public Health Service's syphilis study at the Tuskegee Institute, which began in 1932 and continued for 40 years until it was exposed as ethically unjustified. The study tracked 399 black men in rural Macon County, Alabama, who had syphilis, and another 201 who supposedly in a control group. PHS never informed the participants that they had the disease and simply told the men they would be treated for bad blood, a catch-all phrase for various illnesses. Ultimately, the federal government would surveil the men to determine syphilis' impact on the body's organ systems when left untreated. As a director of Tuskegee University's National Center for Bioethics in Research and Health Care, Reuben C. Warren knows the history all too well. According to Warren, PHS fractured the relationship between the federal government and the black community by lying and withholding treatment and marring Tuskegee's history in the process, an institution founded by the renowned black educator Booker T. Washington for the academic and vocational training of black professionals. In 1997, decades after the study was exposed, Warren, then the Associate Director of Minority Health at the CDC, a position he held for 20 years, was part of the coalition of scientists and public health officials that called on President Bill Clinton for an apology. Following the apology, the federal government, at the coalition's request, established the center Warren now heads to ensure that a project like the syphilis study wouldn't happen again. Warren says that at this moment in the coronavirus pandemic, governors are now choosing who shall live by reopening states, drawing parallels to moments like the Tuskegee syphilis study. Warren explains why this is a matter of ethics and a false choice between health and economics, as the issue of black distrust only worsens. And you have a person that's interviewing this person, and so this is the first question. When you heard about the novel coronavirus, particularly about how it was taking the lives of black people at a disproportionate rate, what was your reaction? And Reuben C. Warren stated, my initial initial reaction was more of the same. I was not surprised, nor was I surprised that initially public health officials and political officials did not want to collect race and ethnicity data because they knew what would tell them. You count what you think is important, and you ignore what you don't think is important. They refused to do something until the demand to collect data grew. Many people say black people have a disproportionate burden of disease like heart disease and diabetes. All that's true, but the current challenge is black and Hispanic folks continue to be at risk. They are the workers. They are the ones who are not getting the PPE. So that's the personal protection equipment. They are the ones who can't afford to stay at home. In the African American Petri dish, my colleague Ronald Broadway of Morehouse School of Medicine and I discuss how African Americans are in the high exposure Petri dish positions since they are the ones often on the front lines, and this presents a greater challenge. So we don't want to get sidelined by focusing on the historical issue of health disparities, which is important, but if you look back to move forward, the current conditions we face are worsening the problem. And said, the question is, what are your takeaways now based on how you see the coronavirus impacting the black community, and what does this mean for the black community? And Warren states, the takeaway is devastation because we know better, but we're not doing better, especially when it comes to testing. Testing is important, but it has to be not only for those who show signs of infection. We now know that people can be asymptomatic. To test only those who have signs is naive at best, intentional at worst, effort to not acknowledge the depth and the breadth of the coronavirus. We already know that without testing, it is going to disproportionately impact people who are at greater risk, particularly African Americans and Hispanic Americans. Then equally as important are the isolation and the follow-up. This is a challenge, and assessing healthcare is a challenge. Black people disproportionately lack access to healthcare and primary care doctors. So then there's the fear of going to the emergency room. This problem is worsening. And the question is, outside of Tuskegee, what else can you point to explain black mistrust in the medical community? He said it's rampant. You might have heard the name of Marion Sims, who was the father of gynecology in the 1800s and early 1900s. Sims tested vascular surgical techniques on enslaved black women without anesthesia. He tested and retested them like this, and he is the father of gynecology, and he even published an article on these women. There's a study in the early 2000s called Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare, where scientists looked at healthcare delivery and found that there was a disparate difference between the quality of care given to blacks and whites, even with the same economic status. Then there's another classic, the 1985 report of the Secretary Task Force on Black and Minority Health. This documents 60,000 excess deaths in the black population each year. Excess deaths mean using the death rate of the white population and comparing it to the death rate of the black population. There were 60,000 excess deaths each year due to 6 causes: cardiovascular disease, stroke, cancer, diabetes, unintentional injuries, and infant mortality. Then in 1992, AIDS and HIV became the 7th. Then in 2002, David Satcher, the former Surgeon General, did this analysis again and found that the excess deaths had increased to about 83,000. So today, the problem is clear. We need not revisit the problem again and again. Let us move toward doing what we know can alleviate the problem. Let's prioritize resources based upon need, not based upon politics. Consistently, the black population demonstrates the greatest disparity. Therefore, it's where the greatest resources are to be committed, but it's not happening. It's not happening. And it said Georgia, in a state where black people are disproportionately affected and dying from COVID-19, has reopened during the pandemic despite expert advice that says stay-at-home measures should remain in place. So it said the vulnerability is clear. There's a 1974 book by Victor Fuchs titled Who Shall Live? Health, Economics, and Social Choice. Like the title of the book, we have to decide who shall live. The historical record and current practices suggesting something very scary. Some folks who happen to be in power will have to describe who shall live. There's a notion called a herd immunity, and that's what they're doing in Sweden. There are people going about their normal day-to-day with no social distancing. They've just accepted that certain percentage of the population is going to die. But Sweden has a different demographic than the United States. Those who are at greater risk here are people of color. They are most vulnerable to live and the most likely to die. Regardless of income, education, across any demographic, the black population disproportionately suffers. Right now, the messengers don't look like those who need to hear the message. The county asks for trust, and I would argue that until those leaders at whatever level demonstrate trustworthiness, trust will not be forthcoming. Shift the paradigm from those who are the most vulnerable to those who have the most power and authority. Trustworthiness and framework or work, not trust. And next question is it ethical for these states to reopen now during the pandemic? And Reuben C. Warren stated, no. I think it's the priority of health over economics. The decision is that clear. There's no either or. Health is the priority. Public health ethics is based upon the population as opposed to individuals, and to resolve public health issues, we look to three constructs. The first is community engagement. The second construct is not benevolence, but beneficence. What are your intentions and what are you going to do? The third is social justice, doing what is the best interest of the population at the greater risk. It's not the whole population, and that would instead be the utilitarian principle or the happiness principle for the greatest good, but at the expense of those who are suffering. The utilitarian principle does not work in a diverse population, particularly when subsets of the population have been historically disadvantaged and abused. The bioethics does not work in this construct. It's a valuable principle, framework, and concept, but it doesn't work in population-based challenges. This is a public health challenge, and the response and the resolve have to be embedded in public health ethics. And that's what we're not getting right now. We're not getting the people that need the medical help the most are the ones that are getting the least help. They're the ones that are getting the least tests. They're the ones that are getting the least admission to the hospital to fight the coronavirus. These people, your people, you, just people like me, black, Hispanic, old, people with bad health conditions. These people are not getting the same treatments, and they're not getting the same. They're definitely not having the same results because these people are being murdered by a lack of medical treatment and a lack of medical health. And this is basically by choice. They are choosing to see who lives and who dies. And at this point, it's like minorities are the ones they're trying to eliminate. So therefore, minorities are the ones that are getting no treatments. So it's time, folks. It's time to wake up.